I'd like to open or provide a time open to the floor. If anyone's got questions, comments they'd like to ask of the speakers, we'd be very happy to answer. I see Andrew Scheiber, his hand in the back. Andrew?
As a male, would it be better to try to speak more gender aware in the space together?
Kalvanya, can ask you to respond to Andrew. What would you like to see? I mean, I will give it other people a chance, but if you'd like to speak.
I think for Andrew, we've been doing this for a long time, and I've also spoke to some of my colleagues around this, is that we follow an international standard recommendation of provision of services for women, right? And I've been contemplating and been thinking about this for a while, even during my implementation years, is that we should implement programs for African women in an African context for their needs and their understanding. And we follow targets, we follow numbers, we follow indicators, but we don't follow the quality of the journey of this individual, right? And even if it means that you take one woman through that journey, you're empowering an entire nation. So I think to answer your question really is to enforce our services to an African woman in an African context. My journey as an Indian woman might be different to Dee's journey as an African woman, right? And so that's what we're missing. We're missing there's a gap between taking an international standard and implementing services where you don't understand someone's cultural background.
Thank you, Dee. Would any of the other panelists like to respond to that?
I think for Africa, drug use is more of poverty and exclusion. And it would be wrong from a researcher perspective that we would implement programs at the healthcare alone and forget about the behavioral, the psychosocial, and the economic needs of that person. It's like you're just doing 10% and you leave the 90% to oblivion. Yeah, so we need to rethink what really works. I'm aware we copy a lot of these policies from the West, but this is Africa. We need to adapt and localize it to our condition.
Thank you very much. Charity.
So thanks, Bernice, for mentioning the part about universities. And I think it goes back to what I presented on yesterday about power and how we've seen how drug prohibition has given power to police, which I spoke about. However, we don't realize that universities, institutions have also implemented their own drug wars within their policies. So universities have their own policies around discriminating against people who use drugs. Labor departments have policies to discriminate against people who use drugs. We've seen that with cannabis cases. So even when we're advocating for decriminalization or reforms in policies, we shouldn't just be looking at national policies, but also looking at the different economic or social spaces that people really navigate in their lives. And it goes back to what you said. We need to start looking at the economic effects of what are we really advocating for. Let's not just look at reducing the arrest of people, but let's also look at the areas that they're navigating in their everyday lives.
Thank you. Another question, the gentleman at the back.
Yes, thank you. I think my question is Stacey. Stacey, I'm from Paul, so also Cape Winelands, and I want to just talk to you about fetal alcohol syndrome, which is obviously in my community, it is the obviously biggest harm that I see. We talk about a lot of kids being basically born disabled. Does the liquor industry take any culpability for that, and how much do they fund harm reduction for that? Because there's a lot of money needed for what we need to do there.
Yeah, so quite interestingly, we are the only country where liquor or a beer is cheaper than a loaf of bread. It's a very, very sad and very real truth. So as much as they are giving, there is a lot going on in the background as well, in terms of promoting and supporting other agendas. So it's not an easy question to answer, but I think it's very clear.
Is there an opportunity for a class action? I mean, because it's really serious. I mean,
I agree.
This is, I know it's a big target here, but
So I do understand that there is a policy currently being developed, I think, by the provincial Western Cape government, or they're looking into alcohol harms reduction, where we all had an ability to give input to, with a promise by Premier Windy that every single piece would be heard or email would be read. However, you need to also understand that the liquor industries at the same time are pushing to make sure the shebeen owners and everybody else gets, you're taking bread off my table, etc., etc. So, yeah, I don't know if there's a clear answer for you.
So, yes, I will ask it. Yeah.
Thank you very much. I would like to say a word of comment to Stacey on the work she is doing, because I'm also coming from Cape Winelands in Stellenbosch, from the informal settlements. And the way she is portraying is the same way that is happening in our district. And I also started a small organization, of which I'm happy that now that I will work with her, we communicate. And I'm also a member of the LDEC of Stellenbosch Municipality.
Wonderful. Thank you for being here and sharing. Gentleman in the blue check shirt.
Good afternoon, colleagues. I was listening to all the presentations, and my one thing that maybe we can put in the back of our heads is my concern is our underage women in drugs, advocate also for the youth, as well as we need a cycle or a network of care, because as we're dealing with both users, recreational users, as well as addicts, we also have this network of issues that they've got. So that network, we're talking about places of safety. From after the place of safety, they need that whole cycle, you understand? So we cannot just say, okay, we're just dealing with this episode. We have a lot of elements that we should remember in the background. When we go back to the ground, that whole cycle we need to remember. It has to be in place and have something that is moving and constant. And as you said, let us not end. Because I've seen, I've had a working program which end, and that glorious blessing that used to happen does no longer happen.
Absolutely.
As much as we can say, no, they will take our program and they will maybe make it into a facet of the GeoH version, it does not happen. But there's also the risk factors as well as geographical locations that I was talking, because we have alleyways. We have the dingiest of places that we find our patients at. But then we cannot, we also have the risk factor of going to these places. So how do we get to our clients? So these are things that I say, let us go back and think about those. Thank you.
Thank you very much. Would anybody like to respond? Can I ask Demokatso? I know I'm asking Demokatso because I know that COSUP do work in with hard to reach populations. So perhaps, or I can refer to Hendrik just to share for us on how are you reaching those hard to reach populations? What strategies do we have, or specifically hard to reach women? Yeah.
Okay, thank you, Chair. I wanted to comment, but I will also answer the question. Because in my comment, I was answering the concern of mine. So I want to appreciate the ladies and the panelists and their presentation. I think what is key is that we need to appreciate that for us to reform, not the policy, the program that we are offering, we must be intentional.
Absolutely.
But that's why I embrace harm reduction, because it says you must meet people where they are. So we need to leave our offices, our comfort zone, our airports, and again, engage with people.
Thank you very much. And I totally agree that when we're talking about meeting people where they are at, we are talking in terms of the full person, where they are at physically, are they in an alleyway, where they are at with their healthcare journey, where they are on their continuum of drug, where they are in terms of their drug use. We need to be adapting our services to meet their needs and not expecting them to adapt to our needs. I've got a question here in the front.
I have more of a comment, so thank you so much to everybody. And I'm looking at all these national things that are happening, and I think to myself, the Commission on
I'm
Gender.
sorry, could you speak up?
Oh, sorry. I'm just thinking about the Commission on Gender-Based Violence, which was done by the Center for Gender Equality, and I asked myself, and maybe there's people here in the room that can get an update, because I guess I'm only just doing a desktop research, but I don't know where's the voice of women who use drugs, or who's supporting their voice being there at the Commission. Because then we'll sit again and say, oh, we're left behind, and the policy documents are already there and the interventions are already there. I know substance use is there, but people are more talking about substance use, mainly managing the perpetrator's substance use, because they see it as a driver to gender-based violence. And so that's just the discussion that I have in terms of intimate partner violence. Where's representation from women who use drugs?
Great, thank you very much. Would anyone like to respond to that?
Okay, well, there is none.
Yeah.
That is the basic reality. And we have a lot of work to ensure that we get women onto those platforms.
Mm-hmm.
The platforms that we can be at, we need to make sure that we bring those women that are able to speak on behalf of others with us. So it is up to us. They are never going to be able to get there. That journey is not possible without us being able to drive it and hold them and mentor them through and make sure that they are there and they're equipped. That's the only way that it's ever going to happen.
Oh, you can hear me. When I asked my client, I asked her about her experience with the justice system, and because I'm like, but girl, you're experiencing all of these things. Do you ever think about reporting? And the picture she painted was that once you get to the police station to report, there's no women's cells. So they leave you at the corridor, and you keep hearing people passing by, laughing at you. You become a whole joker. So it even stops being a pursuit for them. So if I'm raped as a substance user, it's not rape anymore. I don't even identify it as a violation, because then what? And this is why the emphasis of voices and giving them those spaces, like, then what must happen to her? Because there's so much deterrence for justice when it comes to them.
Thank you. Any other questions? Yeah, add on, sure, go ahead.
Okay, I'll be brief. It's on top of this comment, because this is what happened during our lunch break. It was a debate on even reporting issues and psychosocial issues, because now we've got also an element of criminology that is involved here, because our clients, yes, they are on substances, but then now they cannot even report a crime because there's this whole baggage or trailer of issues. I had a case last month where I had a lady come through. She said she knew a whole trafficking wing that was going on, but she was afraid for her life. Mm-hmm. So now where do we go? Because she said if she leaves this office, she's going to die. Now where in our capacity do we have the resources? You see, these are the type of things that I say we already need to get those resources where we can help our victims as well as the people that do need our help, because there is a lot that they know that they can help with, that they can shut down.
but do we have the resources to protect our clients?
And I think that starts largely with the provision of gender-centric services and the provision of having safe spaces within your existing service structures for human rights violations reporting, for having linkage to Tutuzela centers, for having linkages directly with your community safety officer, so that when you hear of an incident like that, you don't expect her to go to the station, you invite your community safety officer to come to see her at your center. We need to start viewing the way we do things differently. Because if we're going to be empowering women, we're going to be uplifting women, we're going to be encouraging women to address these issues, it's a huge shift for them, and we need to be supporting them and doing what we can on our side to assist. Wangari, yes.
I'm from Kenya, and I am going to, I'm thinking about when we give women harm reduction services, we have methadone, we have syringes, to women who are going back to the street. It's ridiculous. And that's what we're doing even in Nairobi. So just to answer the part of, if we cannot give basic shelter, it's not even a very important house, a basic shelter, and we are giving gender-based violence services, do we expect her to leave that boyfriend or husband to go where, when we don't even have a basic one room where they can come and be? So I agree with Africa and our setting. It's poverty. It is just looking at this woman and seeing how can we first of all give her basic, even before we give any syringes and any OAT services. If we don't start with the basic, even the harm reduction services will not be effective for women who use drugs. Thank you.
Thank you. Sister Linda.
Hi, just a comment about we've forgotten that we're in Africa, and the Africans go to traditional healers.
Yes.
So that's where most of them feel comfortable. We need to have discussions with traditional healers on how to approach harm reduction.
Agreed. 100%.
When the
Thank
women-
you.
Yeah.
100%. I think it is a big gap, and it is something we need to be looking at, is how do we scale up indigenous harm reduction? How do we scale up harm reduction to meet the needs or different cultural needs of Africa? Thank you so much for raising that. Any other questions? Yeah, go.
In Kenya, it is happening. I was part of a survey, and we were looking at the involvement of traditional healers in substance use disorders. And in a part of Makueni County, they actually exist, and I think the Psychiatrists Association have already done something about it. And there are several studies online about that. So yeah, even alcohol addiction, there are people who go to traditional healers, and there's the traditional medicine that they use. So for us, it's already happening, it's documented. If you go online, you'll find how a lot of research from psychiatrists who work with traditional healers, and actually they train them how to trace their clients, when do you want to come in, because some people predominantly just believe in the traditional way of life. Yeah. And however hard you will drag them to the clinics, they will still go back to the, are they called the sangomas?
Yep, yeah. Thank you very much. Gentlemen?
Thank you. No, thank you, ladies, for your great presentations. And what is in terms of the gaps that you have experienced, and then what will be your recommendations?
So we have covered quite a lot of those, I think, in the presentations, but perhaps I can ask each of the presenters to mention one or two of their key priorities. Bernice, can I start with you?
Our key priority right now in Kenya is policy reform. We have a bill that civil society is working on. We are looking at domestic funding, how we can advocate for domestic funding, because a lot of funders are going away and reducing the quota. So what happens when funders go out? So for now, our key priority is funding, which we want to come from the government, and then drug policy reform.
Thank you. Stacey?
So I think from within the context that that we work very, very much gender-centric shelters. The GBV aspect is so high. There is nowhere for these women to go, and they have children. So it needs to be gender-centric, drug user-friendly shelters. A key priority for the rural population, certainly.
Thank you, Stacey. Demokatso?
I'm from the research unit, and this data is missing specifically towards female users or women users. And this is what research provides us an opportunity to listen and learn and ask the right question, because the question is as important as the answer. And it will start there. Let's ask the question, let's create platforms and systems to get this information so that it can influence how we provide service. We can only do better once we know better. Yeah.
Absolutely. Thanks, Dee. And Kalvanya?
I think for me the key priorities, and coming from research and not having that data, is really just as part of the Global Fund program through NACOSA, is to really just prioritizing finding the hidden woman. Because as we mentioned, during the course of the conversation, is that the women are hidden and we're finding it difficult to find our women. And so I think it's about prioritizing finding those hidden women where they are, the spaces that they congregate in, prioritizing sexual reproductive health services, prioritizing mothers. So women who use drugs that are parents, through parenting programs, through economic empowerment programs, and also providing some kind of financial relief in terms of emergency assistance for females who need it within the space. Thank you.
Absolutely. Sorry, Stacey, you want to add?
Please, if I can just follow up on that, and I think that is absolutely key, just in terms of data. And it's quite the opposite, I think, from our side, is that we can find those women. We know where they are. However, the data is not being captured. It is in silos, and we do not have a comprehensive picture in terms specifically of the substance use, how much, where, what are the age, all of that type of data that we can actually glean from a simple who assist screening tool that could actually be put right through all the different sectors. And it's being done as a pilot with with UCT, I think, now. But, we were already trying to do that manually years ago, with the clinics and so on. But we need to get this data because nobody's going to listen unless we get the data.
Thank you. I've got time for 2 more questions. Thank you, in the front.
Mine is more a comment, and it's with regards to this issue of data about, especially for us as women in harm reduction. I think we do need to organize ourselves. I think today is a monumentous day in that we have this platform, but we need to organize ourselves because also there's an ethical responsibility when we then think about the oral histories that we'll get and how we use this data. And I would like to see that, I'm not saying we necessarily gatekeepers, but we then set sort of the framework of a safe space for when researchers or the supposed data collectors come into the space. Because we've seen some very unethical practice. I actually got chastised collecting data by a woman who uses drugs at Sunnyside who said, you come here, all of you, constantly collecting our data. When am I going to have a chance to speak to that policymaker? All right, absolutely. So it's that the site is constantly having people coming just collecting data. So I'm hoping that's what we see, in that we organize ourselves a little bit better, and the driver is then women who use drugs. And we talked a bit more about the quantitative side, perhaps for our agenda is not the right methodology. And we possibly have to then look at other more qualitative, which
Amen.
they are a bit more, the researchers know qualitative evidence synthesis, but the ones where, we can give more about the story of the voice, and that sometimes at these policy platforms, we have women who use drugs that are doing the presentations. It would have been nice, Dimakatso, if the supposed client, right, was the one here using storytelling.
Thank you. So I think I just want to add to that we have tried, and we do have in every platform a person who uses drugs. I just think we are used to the stereotypical way they look. And we need to know that for African policy, we are passionate about that, breaking the stigma, and I can assure you that there is a person who uses drugs on every platform. They just don't look the way we think they do. Last question, Wangari.
Mine is not even a question, but I think
Thanks, Klaus.
I think one problem that is keeping women who use drugs from services is we in Africa, and I'm talking from Kenya, we say we are doing harm reduction, but at the back of our mind, we still hope people will stop using drugs. So we've not embraced that it's okay to use drugs. Somebody said something very good yesterday. I am not sick, I just want to be high. Mm-hmm. Because we look at them in a way of, you mean you're pregnant, you're still using drugs. Even if we don't tell them, we are keeping them away with our looks until we accept that drug use is okay. Centuries forever, people have been using drugs, and it is okay. Until we embrace that, we harm reduction providers, we are keeping our women away from services.
Thank you. Thank you, everybody. Unfortunately, we are limited by time, and I think there's some really key points that have come out of our discussions today. Hope that everybody here has at least taken one special key learning lesson away with them. And I just want to say thank you. I know it's late in the afternoon. Thank you for those that came back after lunch. And also just putting on my organizational hat, just to remind everybody that the plenary tomorrow morning at 9 a.m., the role of civil society organizations, evidence from South, East, and West Africa will be taking place in Queen's Room 1 and 2. And then there is a high-level meeting, I think it's a closed meeting for NACOSA, is that correct? No, it's opening. So we'll be looking at funding with regards to harm reduction, and that's taking place in the Harlem Room tomorrow at 9. So thank you, everybody. Have a lovely afternoon. Thank you.